Good morning, everybody. So let's do this case. 24 years old male patient comes to you due to headache since 2 months, weakness since 2 months. You measure his blood pressure. His blood pressure is elevated. So this headache is due to hypertension. His blood pressure is 180 to 100 millimeter mercury. You do some lab work and everything is normal except for a potassium level of 3. So he has hypokalemia, 3 millimole per liter. And basically this is what's causing his muscle weakness, the hypokalemia. So we're talking about a young patient who is coming to you with hypertension. So this is a secondary cause of hypertension. The first thing that we need to ask this patient is if he's having episodic palpitations. If this is the case, then our patient is having pheochromocytoma, but this is not the case. So hypertension plus weakness plus hypokalemia. We think about hyperaldosteronism. We have two different types of hyperaldosteronism. It's either primary or secondary. I'll write down here others. So primary hyperaldosteronism, there is a tumor of the suprarenal gland, or there is suprarenal gland hyperplasia, and it's producing aldosterone. So in this case, aldosterone will be elevated. And because aldosterone is elevated and blood pressure is elevated, then this would result in a compensatory reflex decrease in renin. So in primary hyperaldosteronism, aldosterone is always elevated and renin is always reduced. And we're talking about Conn syndrome, which is basically an adenoma of the suprarenal gland, or we're talking about suprarenal gland hyperplasia. So the gland is basically hyperplastic. Now, let's contrast this to secondary hyperaldosteronism. In secondary hyperaldosteronism, so it's hyperaldosteronism, so aldosterone is elevated. But in this case, renin is reduced. In this case, renin is also elevated. So the problem here is either the kidney is not perfused with the blood, and because the kidney is not perfused with the blood, renin will be produced from the juxtaglomerular apparatus in the kidney, and renin will stimulate the release of aldosterone. So renin, angiotensin, aldosterone activation. The causes here are either renovascular disease. So for example, there is renal artery stenosis. Renal artery stenosis, for example, due to atherosclerosis of the renal artery, or it's due to proliferation of the smooth muscle of the artery. Yeah. And basically the kidney will be not good perfused and renin will be produced, and renin will cause the activation of the renin angiotensin aldosterone system. Yeah. So it's either renovascular disease or it's a reninoma, which is basically a tumor of the juxtaglomerular apparatus of the kidney, or sometimes it's secondary due to diuretics. So the patient is getting too much diuretics, the patient will become hypotensive, and as a response, renin will be elevated, and this will activate the renin angiotensin aldosterone system. Now, other causes. So we said here in primary hyperaldosteronism, aldosterone is elevated, renin is reduced. Secondary, both of them are elevated. In others, aldosterone will be reduced and renin will be reduced. So basically, in this case, it's either Cushing syndrome, or the patient is taking exogenous mineralocorticoids. So Cushing syndrome is actually a recognized cause of secondary hypertension because corticosteroids have a permissive effect for the action of for the action of epinephrine and norepinephrine on the vessels. This is one thing. And the second thing is corticosteroids in very high concentrations will lose their specificity and they will work like aldosterone. So this is the case. So young patient comes to you with hypertension, with weakness, with hypokalemia. Always think about the secondary causes of hypertension. Always think about hyperaldosteronism, especially Conn syndrome. Thank you so much. I need a cameraman. If someone can help me, if someone can edit my videos, then this would be great. Please contact me. Thank you. Have a nice day.